The British Association of Prosthetists and Orthotists, in collaboration with Beth Sheehan Consultancy, are pleased to bring you this presentation on basic walking aids to support balance or weight bearing with prostheses and orthoses. Beth refers to a number of external resources in these slides, and you can follow links to them in the YouTube description.
In this presentation, we will discuss weight bearing and gait, including gait with lower limb prostheses and orthoses, mobility devices and how that fits with the United Nations Convention of the Rights of People with Disabilities and the International Classification of Functioning and Disability Model, as well as the benefits of walking aids. We will also review walking sticks, crutches, and walking frames. Wheelchairs will not be covered in this presentation. Firstly, we will look at weight bearing in relation to sitting, standing, and mobility. In normal upright sitting, our body weight is distributed through various areas of our body. It is important for pressure management and sitting that as much of the patient's body as possible is loaded in their chair, and this includes the feet, a commonly overlooked area. If 75% of our body weight is exerted through the buttocks and thighs, that means the bony prominences in this area, such as the sacrum, coccyx, trochanters, and the ischial tuberosities, are more at risk of developing debilitating pressure ulcers. 16 to 19% of an average person's body weight is distributed through the ankles and heels in normal sitting posture, which could potentially make the feet a high-risk area for pressure ulcers and injuries. To test balance before we transition to standing, you could perform a modified functional reach test in sitting. Pause the module now to watch the video for the modified functional reach test and the normal functional reach test in standing. Once you start to transition from sitting to standing, it's important to train the sit to stand both from a strength and balance perspective. Ensuring weight is evenly distributed through both legs, pushing down through the feet or heels, nose over toes as you push down, and extend the legs up into standing. Krishnan and colleagues looked at body weight percentages across a number of studies. On average, each lower limb is 16 to 20% of your body weight. When we can't stabilize and balance on our lower legs, this has a significant impact. When looking at weight bearing, starting with standing is often easier to understand. However, if you were training someone with an injury or pathology, you would commence with sitting, then progress to standing, and then walking. In the picture on the right, you can see that the center of gravity runs down the middle of the body with the ground reaction force pushing back from the floor. The weight is evenly distributed through both legs. In a normal stance pattern or standing pattern, the body weight is evenly distributed like in picture B, with the symmetrical left and right sides of the body. 50% of the body weight is transferred evenly through both legs, making this 100% of the body weight. Difficulties in weight bearing and weight transfer may result in impaired mobility and balance, increased fall risk, and decreased community engagement. Let's look at the impact of lower limb loss on balance and weight distribution. In this example, we are looking at the alignment and weight distribution for someone who has had a very high transfemoral or above knee amputation. When standing, we need to consider that the individual has lost a significant amount of body weight with their right leg being amputated. As per the previous slide, if one leg is 20% of the body weight, losing this limb will result in significant changes to balance. When prescribing a prosthesis, there needs to be consideration of the weight of the prosthesis, as well as the retaining of balance and realigning of the center of gravity. When working with amputees, it is important to include balance retraining to assist with standing mobility as well as sitting, which will be discussed on the next slides. Whilst discussing pathology, let's move to an orthotic example. In the case on the right, we are looking at hemiplegia as a result of stroke. In figure A, this individual has had a stroke affecting the right side of the body. 73% of the body weight is being transferred through the affected right side in ambulation due to the inability to stabilize and support themselves. And this is a potential falls risk with the body significantly leaning to one side. When paralysis occurs on one side of the body, this will obviously impact the center of gravity and ability to weight bear evenly on both legs. Balance retraining is important to prevent falls and falls risk, and will require a combination and will potentially require interventions such as orthotics, for example an AFO, and it may require a walking stick or mobility device. And for some of the more advanced cases, will require standing frames. In this particular case, a heel lift was utilised. A multidisciplinary approach will be required to assist with the interventions as well as strength and balance retraining. In the gait cycle, we know that one leg is in stance phase for 60% of the cycle and moves through to swing phase for 40%. When discussing the single leg stance phase, 100% of the body weight goes through one leg, predominantly during the mid-stance phase, so the 10 to 30% of the body of the gait cycle. The body's momentum then shifts from one leg through to the other, and so that the initial double support phase is essentially 50% of the body weight going through each leg in a normal gait cycle. When we have an injury or trauma to the body, working with a multidisciplinary team is important. The physiotherapist or physical therapist will often prescribe exercises based on the amount of weight bearing that can occur to ensure that the bone or ligaments have adequate heal time, yet strength and balance are maintained. When non-weight bearing exercises are prescribed, this means that no weight can go through the foot or the lower limb, for example in a fractured foot. This is often when crutches are prescribed to ensure the individual can ambulate, but put no weight through the injured limb. The definition of toe touch weight bearing is poorly defined in the literature. In clinical practice, it is commonly described as having the ability to touch the foot or toes to the floor without supporting weight from the affected limb. The pressure should be light enough to avoid crushing a potato crisp under the foot. Partial weight bearing is a broad term and can range from anything greater than non-weight bearing to anything less than full weight bearing. Partial weight bearing is usually accompanied by a percentage figure to further describe the extent of recommended weight bearing. Most of the definitions in the literature define partial weight bearing as being 30 to 50% of a patient's body weight. Full weight bearing means no restriction to weight bearing. In other words, 100% of a person's body weight can be transmitted through the designated limb. This term is somewhat interchangeable with the term weight bear as tolerated, which allows the patient to self-limit their weight bearing up to full body weight. For the lower extremity, non-weight bearing, toe touch and partial weight bearing require the use of a wheelchair or assistive device to maintain compliance during mobility. In the case of full weight bearing or weight bearing as tolerated, an assistive device may be needed if other impairments, for example pain, impaired balance, muscle weakness or abnormal tone, act as barriers to safe ambulation or contribute to significant gait deviations. This next video is a good introduction to the different weight-bearing aspects regarding injury, as well as an introduction to assistive devices that can assist with weight-bearing, balance, and ambulation, and these will be covered in more detail. Pause this module to watch this video. When we combine sitting and standing to perform functional tests or functional tasks, such as getting out of a chair, we need to understand the body weight transfer from that sitting to standing phase, as well as the element of balance. Objective measure tests, or OMTs, that would be suitable to look at transfer from sitting to standing would include a basic 30-second sit to stand test or a 3-meter timed up and go test. Other such tests that would work on single leg balance, particularly when we look at the pathology, would be the Berg balance test or single leg stance, for example. We encourage you to pause the module now and review these tests and videos. In this next section, we will review walking with prostheses as a new amputee. The International Committee of the Red Cross, or ICRC, has published this easy guide for lower limb exercises and gait retraining. The booklet takes an amputee from sit to stand and weight transference through to walking in parallel bars and then without assistance. It's an easy guide for clinicians and amputees. Alongside this gait retraining, amputees ideally need to be educated on the type of prosthesis and technology they have. Understanding the locking mechanism for above-knee amputees will be imperative for safety as well as ambulating across different terrain. This next section will discuss a variety of basic mobility aids or devices. The United Nations states that mobility devices are one of the most common types of assistive technologies or devices. Assistive technology can be defined as any piece of equipment or product whether it is acquired commercially, modified, or customized, that is used to increase, maintain, or improve the functional capabilities of individuals with disabilities. Mobility devices are designed to facilitate or enhance a user's personal mobility, and this relates to their ability to change and maintain body position and walk and move from one place to another. The United Nations Convention on the Rights of Persons with a Disability, Article 20, looks at personal mobility. It states that parties shall take effective measures to ensure personal mobility with the greatest possible independence for persons with disabilities, including by facilitating the personal mobility of persons with disabilities in the manner and at the time of their choice and at affordable cost. Facilitating access by persons with disabilities to quality mobility aids, devices, assistive technologies, and forms of live assistance and intermediaries, including by making them available at affordable cost. Providing training in mobility skills to persons with disabilities and to specialist staff working with persons with disabilities, for example, this program. Encouraging entities that produce mobility aids, devices, and assistive technologies to take into account all aspects of mobility for persons with disabilities. When we take into consideration the International Classification of Functioning, Disability and Health, or the ICF model, mobility devices such as walking aids are part of individuals' contextual factors, specifically their personal environment. Mobility devices help to facilitate activities such as activities of daily living, ability to work or participate and function within society. In alignment with the ICF model, the use of prosthetics and orthotics, as well as mobility devices, combined with other interventions such as education, skills, training, job coaching, placement and social support, prosthetics, orthotics and rehabilitation services, contribute towards the overall aim of optimal functioning and work towards participation and inclusion in society. The World Health Organization standards for prosthetics and orthotics aims to ensure that no one is left behind and has access to prosthetic and orthotic services. Whilst mobility aids in many countries may not fall under P&O products, many P&O facilities may stock these products. In alignment with Standards 16 and 17 of the WHO standards, prosthetic and orthotic products should suit local needs and a national priority list be drawn up. The Priority Assisted Products list designed by the World Health Organization also includes canes, sticks, crutches and walking frames as part of their 50 priority products. Benefits of mobility devices include, but are not limited to, improving mobility difficulty, improving independence and participation, reducing the impact on caregivers, preventing falls, injuries or further impairments, preventing premature death, reducing healthcare costs, and improving the quality of life. Now we are looking at the basic walking aids. Firstly, canes or walking sticks. Standard single-point canes are usually made of wood or aluminium. They are lightweight and usually inexpensive. However, usually there is no ability to adjust the height as it is fixed. It is therefore necessary for the cane to be made for the individual rather than buying one off the shelf, as it may be the wrong height and create other musculoskeletal issues. Canes are useful for mild sensory or coordination problems found in visual, auditory, vestibular, peripheral proprioceptive, or central cerebellar disease. Offset canes are usually made from aluminium and the lengths are adjustable with no need for custom fittings. These canes allow for the patient's weight to be displaced over the shaft of the cane. This cane provides more stability and can be used for occasional weight bearing. The type of patients in need of this cane are those with painful gait disorders that affect the hip or knee, for example osteoarthritis. Four-legged or pronged canes are usually made of aluminium. This cane permits more weight bearing, increases base of support, and provides more stability for the patient. It can also stand by itself, freeing the patient to use his or her hands. The disadvantage is that all four legs of the cane must be in contact with the floor during gait to provide stability, which hinders fast gait. It can be prescribed for hemiplegic patients or patients with moderate to severe antalgic gait from osteoarthritis. Finally, a hemi walker cane provides more broad-based support than the other canes. It is used by patients requiring continuous weight bearing through one upper extremity, like stroke patients with hemiparesis, who have moderate to severe lower extremity disability. Walking sticks are used widely to reduce pain and improve stability and balance. However, they are frequently used incorrectly and can be dangerous if not properly maintained. It is important to educate patients on how to obtain greatest benefits from their walking stick and of the necessary to check it regularly for defects to ensure safe usage. Ideally, in conjunction with their rehabilitation or multidisciplinary team. This is particularly important if they're using these walking aids in conjunction with prostheses or orthoses. Walking sticks are used to provide balance and support in standing and walking, take pressure off one or both legs, reducing pain, balance implications, and improving the feeling of safety and security when walking. Some conditions that may use these devices and would be appropriate to use these sticks include gait disturbances, balance, motor issues, joint or skeletal problems. The variety of sticks available also have a range of handles, range of materials, adjustable and non-adjustable, wide range of grips. For example, T-handles, crook handles, swan neck handles, and ergonomic handles, as listed in this table taken from Physiopedia. We encourage you to pause this module and go to the caregiver's video on how to prescribe a walking stick and what safety precautions to look for. This video also discusses gait and how to ambulate up and down stairs safely using a cane or walking stick. This video was specifically designed for a residential home, and so patients or clients are referred to as residents. It is important for service users, caregivers, and allied health professionals to understand the correct height and prescription for walking sticks. For walking sticks, measure from the floor to wrist height whilst wearing your regular shoes. If the shoe height changes, the walking stick height may also need to change. When ambulating or walking with a stick, try to remember the following. Place the stick or cane in the opposite hand to your injured or affected leg. Move the walking stick at the same time as your injured leg. And as you step forward with your injured leg, plant your cane slightly in front of you. We encourage you to pause this presentation and watch this NHS video that demonstrates how to stand, sit, and walk with a walking stick. Now let's discuss the different type of crutches. Firstly, axilla or underarm crutches should be positioned about 5 centimeters below the axilla or armpit with the elbow flexed at about 15 degrees. This design includes a bar under the armpit or axilla, a handpiece, and double uprights joined together by a single leg or pole. They are adjustable in height. Both the overall height and hand grip height can be adjusted. Here you can see the practical aspect of using crutches post-amputations and prior to receiving a prosthesis. The second is forearm crutches or loft strand, elbow or Canadian crutches. Their design includes a single stick, a forearm cuff and a hand grip. The height of the forearm crutches are indicated from hand grip to the floor. They are usually adjustable as well. These are good to use when the client is allowed to partially weight bear and can maintain good balance. These may be seen in conjunction with the use of orthotics, for example AFOs. Gutter crutches or adjustable arthritic crutches or forearm support crutches, and these crutches are composed of padded forearm support made up of metal, a strap, and adjustable handpiece with a rubber covering. These crutches are used for patients who are on partial weight bearing, like rheumatoid disease, and provide less impact through the wrists. Hands-free crutches can be used for those that can still weight bear through the knee, but need below the knee to be limited, for example when wearing a moon boot for fracture management, or for those with below knee amputation. We have briefly discussed the measuring of the height for axilla or armpit crutches on the right. Remember, they need to be 5 centimeters under the armpit to avoid any irritation, encouraging individuals to take the weight through their arms and wrists. A wrist strengthening program may need to accompany the rehabilitation program, particularly for long-term use of these crutches. For forearm crutches, the forearm cuff should be 3 centimeters below the elbow and the hand grip at wrist height as per the diagram on the left. To stand with forearm or loft strand crutches, hold both crutches in one hand in a H shape. Place your other hand on the arm of the chair. Push up from the chair to stand up. And once standing, put your hands into the crutches, ready to walk. Place the crutches in front of you to maintain your balance. To sit, take both your arms out of the crutches before sitting down. Place both crutches in the one hand in a H shape like before, and feel for the arm of the chair with the other hand as you sit down gently. When an individual is unable to weight bear through their affected leg, put both crutches forwards in front of you, just wider than hip width apart. Keep the injured leg off the ground. Take your weight into your hands, pop forward on your good leg to land between the crutches. Please note that this is the same concept for axilla crutches. For an individual that can weight bear through the affected leg, place both crutches forwards in front of you, just wider than hip width apart. Step your injured foot forwards between the crutches and take the weight through your arms and leg to step forward with your good leg. Put both crutches forwards and repeat. And again, this is the same concept walking with axilla crutches. Going upstairs with or without a railing, you want to keep the crutches on the stair you are standing on. Push through your hands, not your armpits, and bring your good leg up to the next step. Let the injured leg trail behind. Straighten your good leg and bring the crutches up along with your injured or affected leg. When going downstairs, put the crutches on the lower step while putting your injured foot forward. Support your weight between your crutches using your arms and again, not your armpits, and move your good foot forward to the lower step. A walker or walking frame is a walking aid that has 4 points of contact with the ground and usually has 3 sides, with the closest side to the patient being open. It provides a wider base of support than a walking stick and is used more to stabilise patients with poor mobility and balance. A four-wheeled walker could be one of the following. It has 2 front legs with 2 rear casters, or 2 front legs and 2 rear wheels, as shown in that top picture, or square wheels. In some countries, you may also have access to a modular kit with interchangeable parts to make frames and other mobility devices. Or you could have a four-wheeled walker and transport chair all in one. Zimmer frames, as featured in the bottom picture, are mobility devices used for people with restricted mobility and who struggle to walk unaided. Usually, they are made from lightweight materials to accommodate lack of strength, but usually do not have wheels to try and limit the risk of falling even more. It's important to know how to use walkers and wheeled walkers properly. Ironically, walkers or frame use has been associated with an increased risk of falls in both the community dwellers and those who live in residential care. Using a walker can also increase metabolic and musculoskeletal demands, so prescription and education is key to helping the user maintain their balance, minimise their falls risk, and optimise their activity levels. It's important to educate your patients or clients on how to ambulate correctly. Let's watch a short video on ambulating with a walker created by Tan Tock Seng Hospital in Singapore. Pause the video now. We also encourage you to pause the module and watch this falls prevention presentation that looks at wheeled walkers as well. In conclusion, we hope through this presentation the participants now have a better understanding of the role of weight bearing and transitions, and how this translates to the role and importance of a variety of mobility devices to improve the quality of life for service users of the prosthetic and orthotic sector. Underpinning these concepts is the United Nations Convention on the Rights of Persons with Disabilities and the International Classification of Disability and Functioning, and we hope that using these frameworks continues to enhance your professional practice.
This presentation is part of the BAPO Learning Suite of Resources. For more information, visit bapo.com.